everyone. Hi, everybody. Welcome to the PPCM Awareness event, virtual style. This is May 11th, 2024. Our event will be from 11 a.m. to 2 p.m. today. All content found on Let'sTalkPPCM.org, our website, including text, images, audio, or other formats content were created for informational purposes only. We are not physicians, medical providers, or mental health professionals. The content is not intended or implied to be a substitute for professional medical or mental health advice, diagnosis, or treatment. Okay. Here's some of our topics of discussion today will be about us Talk PPCM, the organization, the importance of PPCM awareness, the insights from the cardiologist, empathetic healthcare, call to action and getting involved, college professor in health science, mental and emotional health, and the Q&A session. Okay, so a little bit about my journey. I'm Brianna Harris Henderson, and I was brought into the advocate awareness and public speaking world when I had lost my sister, Crystal, who developed PPCM unknowingly after the birth of her second child, which is right here in this top left picture up there. That's us before health issues, before anything went downhill. The next picture would be of her and her kids when after she found that her heart was bad and that she, would need a new heart. And so that's where she was at. She was waiting for a new heart before they had sent her home with high IV therapy, and she ended up passing at home. So then it brings me into myself there. The third picture there is me and my daughter. And obviously, I was having some breathing issues a little bit after I had her, but of course, me, the nurses, we didn't take it as far as of a concern as, what was taking place actually on why I couldn't breathe, because I did go through a postpartum hemorrhage, and that postpartum hemorrhage, did a lot of damage to the blood. I mean, to my blood, I lost a lot of blood. And so from there, I was having some complications then, some fluid retention. And I think that's all I remember as far as in the hospital. I do remember asking the doctor, well, my obstetrician, to see how she could check my heart, though she wasn't a cardiologist. But I just, I told her I knew that wasn't her role, but I just felt I would feel comfortable before leaving to make sure my heart was okay after losing, I think, 2 liters of blood is what I lost. Okay, so then that brings me to 2 months later, literally after asking for that heart check, I ended up getting heart failure symptoms basically. So over that time, over the 2 months passing, I had got diagnosed with peripartum, well, actually postpartum cardiomyopathy. But we've been taught by Dr. James Fitt that to coach it as peripartum cardiomyopathy because it actually starts in the pregnancy. So somewhere it's starting in the pregnancy and then it flows a little bit after. But the only thing about my situation that made it look differently is because um, when I was diagnosed, I did have symptoms I remember as pregnancy, but when she checked my heart, they did an echocardiogram, and I remember looking at the results, and I saw, I think it was like 46% on the right side, and then I think it was like 55 or 60 on the left side, if I'm not mistaken. And so it wasn't really, I guess, a cause for concern then. But then those 2 months later is all it took for me to be at 15 to 20% or 25% of heart function. And so then it goes into me, hey, being an advocate, spreading into awareness. I end up releasing an actual book that's called The Life on Pause, and basically explaining my story, who I am, where I came from. I know, because a lot of people is obviously interested in learning, like, how did this organization even pop up in the beginning? I mean, to begin with. So I wanted to be able to introduce that. Then it goes into me. I actually end up becoming, from being an advocate, I became a doula, wanted to be able to help other moms and just be able to be in the rooms with them as, seeing what goes on behind the scenes, something that maybe can be caught on time, something, a word, words go a long way, or just being an extra ear or, extra eye, it can also go a long way as well. So that has been teaching me a lot. And then we also, partnered or we do partner with healthcare professionals who partner with the healthcare professionals who partner with birth workers just to make sure that they're educated and staying up to date on basically what we're seeing with all the new moms that's getting diagnosed. Obviously we want to make sure that when we do get to new moms, we want to make sure that we're catching on time. So that brings us into where we do the BNP blood testing. We had started that about 2 years ago, just being able to merge with other teams of doctors and in their offices or their practices, just to make sure that. So it's basically a program that we had created, and it was basically creating mobile BNP blood draws. And so that was like a 12-month project that we did, and it was basically revealing that moms who are basically interested, the ones that are interested in learning more about their health, and then you have some that just like, I don't know, it's so it's like we're trying to figure out the best approach as far as how to get moms more aware of what their body is going through, because we can help the doctors as much like me telling my doctor that, oh, I feel like something's wrong with my heart, but other moms may not know to say that. They may not know that it's something wrong with their heart, because the only reason I did because my sister went through it, right? So of course it was going to be something there in the back of my mind that was going to make me feel like I need to, um, ask this question. And so that's another picture right there where it was a selfie of me getting that blood draw done for that mom. She was concerned because she had developed preeclampsia. And so she developed preeclampsia, and then she was forced to get a C-section. And they didn't let me in the C-section room because, at that time it was around COVID time. So they was like, oh, we can't have extra, individuals in the room. So we weren't able to exactly pinpoint to see how to document that situation on how as far as birth experience had went. But once she got home, she was doing pretty good. Her BNP levels was great. I believe it was like a 15. And so she was no worry to us. But also, I'm not sure if you can see right there, it's a laptop that's right here in this area, and that's where the nurse practitioner is actually doing the screening questionnaire. So we do wanted to introduce the screening questionnaire today as well, so that other healthcare facilities will be aware that they do have something that we can kind of help maybe possibly bridge the gap, or at least preventing the mom from being able to increase. If we're seeing an increase in the BMPs, we want to be able to collect as much data as possible on that. Then I've turned into a speaker as far as advocating. I was able to partner with the Texas Health and Department Human Services, so that was pretty cool. And then we had got Greg Abbott to be able to approve our proclamation. He's been actually approving it for the last 3 years now, and so this is year three, being able to have an actual dedication a week in the month of May, surrounded by Mother's Day. And happy early Mother's Day to all the mothers, by the way. And so that's another thing that we was actually celebrating for the last two events. And so then we also have, or we have, we call them patient advocate, what was our PPCM patient advocates. And with our PPCM patient advocates is basically moms who have survived the condition, and they are, willing to get trained or training themselves. We're being able to offer that experience to them so that they can get a feel, because a lot of them want to go out and obviously save other people's lives. Like, it's just, it's not it for everyone, but the ones that it is for, it's, you feel like it's a passionate thing that you need to be doing. You didn't develop this condition for no reason. You developed it for a reason, a purpose that we just probably don't know yet. But we know that it has to be something to do with helping other women, because this is a dreadful condition to go through, especially while you're in motherhood or early part of motherhood, and you may have other kids as well. And if you have other kids and you have this new baby, and now you're slowing down because now you're on all these medications. The medications make you so sleepy. You can't really function properly. A lot of moms don't have support, and so it's just a lot of things that transpires. And, speaking of that, we do have um, some different projects that'll be coming up soon, as far as to go into more details as far as what we're dealing with behind the scenes. And so It also brings us into to this last row here. I did release a music video because I'm just a fun and talented individual, and I just love to be able to exercise all of my skills that I've learned growing up. So being actually music, I love music, so that was just something that I felt like in my heart. I said, "Oh my goodness!" I said, it's so many things that you can do in music because obviously a lot of young people, right? Like they follow the music, they listen to what they're hearing, if they bob to it, if you're able to move so that was just a thought that came to my mind while I was literally sitting at work one day, and I was like, "Oh my goodness, I'm gonna just write it as a little rap song or something, and just do what it do." And it started collecting a lot of attention. This was around 2020, so a lot of people was at home, right? They was able to just sit there and listen to it, and so it really sparked some conversations, and other I was able to get reached out to by other organizations who thought that it was just a brilliant idea that they wanted to start doing it too, and so they wanted information on that, and so that was pretty cool experience. And then we've been starting on our magazine. We're trying to get a magazine released where we'll be able to have these free magazines placed in the doctor's offices or the medical care provider offices or birth workers. Obviously we be seeing the magazines that's sitting there, and sometimes we just get bored sitting in the waiting room and we want to pick up something, and who wouldn't pick up something that looks like pregnancy related, especially if you're in the OBGYN, if you're in the midwife office. So we want to be able to definitely raise enough funds for that to be able to get those out. We're not sure exactly the amount yet, but I know we're going to need over 2,000 of those magazines to just start placing as far as like in the local hospitals. And then we want to eventually just start kind of having them placed in different states because our horses are everywhere. And so the PPCM patient advocates, when they do get trained, they'll be able to have access to everything, all the information and the supplies that they would need. So in their states, they'll be able to provide that for their medical providers and everything. We also captured my story under the CDC Hear Her, which is also part of the Texas Health and Services, which they partnered with CDC to be able to release that cool project that they had going on for basically maternal mortality awareness, and then just have some gear, some shirts and stuff. We have other things now, but that's just one of our populars. Is our shirts with the little baby face on it, and the baby face created that. It was actually a thought that I had in my mind as far as like I know it affects. Um, Majority of African American women, and so like I wanted the baby to be kind of a tan color. There's like as far as a mixture, a mixture of races, and so to try to be able to acknowledge the fact that I do know that they're telling us basically based off scientific methods that more women of color have been developing this condition. So we want to make sure that we're definitely attracting them. Make sure because we know that a lot of African American moms we don't know what to be educated on as far as like our bodies. Like we're learning, we're trying to figure out what's right, what's the best options, because we're not just taught on, oh, you're supposed to do this, supposed to eat this, supposed to do, so it's a lot of things that can transpire as far as like with this condition alone, and then who it's affecting, and then we also seeing a lot of more deaths as far as, and even my sister, she passed away, and her color, they look at everything, as far as, to put that data together. Okay. So that brings us into what postpartum or peripartum cardiomyopathy is, and that it can happen in the last month of pregnancy or up to 12 months after you give birth, and it could affect you even if you have no previous signs of heart disease. Healthy women with no risk factors have experienced PPCM. Healthy women with no risk factors have experienced PPCM, which is our overall cause on why we're trying to make sure that we're bringing awareness to this dreadful condition because don't nobody want this condition. Okay, so peripartum cardiomyopathy, PPCM, is often unrecognized and misdiagnosed form. We don't like to really say rare because saying rare is basically deviating the mothers who probably would need to know that this can affect them. Because obviously, me and my sister didn't have no prior health conditions. We didn't have no reason to be developing PPCM, other than that our mom died of breast cancer like when we were younger. That was the only thing we were told to look out for. No heart complications or anything like that, pregnancy, what to look out for. So we just want to make sure that we saying certain words that can trigger certain things as far as like raising awareness around this condition. So it's an often unrecognized and misdiagnosed form of cardiomyopathy that occurs in pregnant women and recent mothers, and is often misdiagnosed. Okay, like in my sister, it was misdiagnosed. My situation was different than hers. I ended up being diagnosed only because it was like a 3-year difference, and my doctor was like, "Oh, well, they have a lot, a little bit more information now." So it was kind of sad at the same time. So yes, I did go through survivor's guilt. Um, so PPCM it causes your heart to become larger around the time of delivery, which is why Dr. Fed had suggested that we call it as peripartum cardiomyopathy versus postpartum. And then that enlargement weakens the heart muscle and makes the pumping of the blood, more difficult. So we do have a little preview as far as over here as the PPCM screening survey that we have that we've been trying to introduce. I have it small like that for a reason. And so we're just trying to be able to educate as many healthcare professionals as well, because we have a lot of new doctors that's coming into the field, and they're saying that, oh, wasn't, it was this little bitty passage about it, but it didn't really go into like a full detail. So they've been needing more information about this condition. And so we're, definitely overjoyed and welcome to help to bridge that gap, because it was just a difficult situation, and watching my sister's children's grow up without her is difficult as well. And so we have the risk factors as far as like what we've been seeing with the moms that we do have, and obviously we have like over 5,000 women who we have been able to help collect data from, and it's we identify the risk factors associated with PPCM per Dr. James Fed. You can look up Dr. James Fed. He's a good cardiologist that actually studies PPCM. So including age, multiple pregnancies, African descent, the pre-existing heart conditions, and certain medications is what we, if moms are on certain medications that could probably trigger, this condition as well, because the condition obviously can be triggered. The stress, the significance of monitoring higher risk individuals closely during and after pregnancy, which is what we've been trying to bridge that gap in, as far as like sending the nurse practitioners or being able to have virtual visits for those mothers, so they won't have to be doing too much. A lot of moms don't want to get up and go to the doctor. They want to be there at home. So it's like, well, how can we help at home other than having dual support and, just those supports where they can be visited at home. So we're trying to definitely make sure we're broadcasting and creating more around that. We do see that like with older women, as far as 30 years plus, that's developing that condition a little bit more so than the younger ones. But the young ones, that doesn't exclude the young ones, because we have been seeing a lot of young women developing PPCM, and I was one of them. I was only 23 when I was diagnosed, but we had mothers who was young as 16 and 18, who's getting this condition freshly out of high school or in high school, and they have to deal with heart failure. So, and then we have the preeclampsia and eclampsia. Those we've seen that a connection there, that we've been seeing that a lot of women who obviously develop preeclampsia sometimes may go on to develop heart complications later, and then it obviously gets diagnosed as PPCM. And then so being African American, as we heard, that's basically like one of the main risk factors. We have the family history of heart disease. Sorry, my voice going out. We have the family history of heart disease, which is like what we saw with my family. Not only did my sister die from heart complications, but our grandmother, our maternal grandmother, actually developed some heart complications that she didn't discuss until my sister went through those complications on her end. And so she was like, yeah, she was told to not have any kids after her third child, and that was in the 80s. And so we're like, okay, well, we didn't know about that, so that was something good that we could have been aware of, that probably would have had it in our file. And so then high blood pressure, then we also see like an increase of high blood pressure. Some moms get up to 200, plus for their when they walk into the ER and they literally just had a baby. So sometimes that's missed because we don't know how to feel or what we're supposed to be feeling when our blood pressure is up or down. Then we have the multiple births. So just if moms that done had pregnancy multiple times or been pregnant multiple times, then we also that's a mother that you could kind of keep a little close eye on as well, just to make sure she doesn't develop anything like this later on in those births, because she's not going to be looking out for that. We want to experience our pregnancies the best that we can without having to worry about nothing dreadful happening to us. So then heart murmurs. My obstetrician, she did hear a heart murmur when she was not diagnosing me, but when I had asked her to listen to my heart, she did hear a heart murmur, and that was around like 36 weeks of pregnancy. And so that was not really a cause concern for her, because she said it happens during pregnancy anyway. Then the hypermesis, the HG, that symptom is what we've been seeing. Risk factors, what we've been seeing women that develop that. I know that my sister suffered from not HG. We weren't diagnosed with it, but we suffered from aggressive nausea throughout the whole pregnancy. And so we do have other moms who've been experiencing that as well when we do the little surveys in our postpartum PPCM group. So we've seen a trend in that. And then fertility treatments, as far as women that go through IVF, we've been seeing an increase as far as the women who have these certain medications placed into their bodies, not knowing if they carry this PPCM trait or not. It could be triggered, obviously by IVF. We also have that information under with Dr. Fett, Dr. James Fett as well. So we're actually learning. And then around 2020, he included COVID-19 as well, because COVID-19 also has been seeing some connections there as far as like heart complications like that will happen later, and then especially with mothers. So we've been trying to keep an eye out on that as well. Okay, for our preventative measures, we'll discuss the potential preventative measures such as careful monitoring during pregnancy, early interventions, what we're about, and awareness of risk factors. So making sure that, like that with our doula project, just making sure that we're able to be a listening ear, seeing exactly what's going on in the rooms, and just trying to make sure we're able to collect enough information as possible to make sure to see if it's another bridge, another gap in the bridge there, as far as like connecting with the doctors or with the birth workers. So we like to encourage the healthcare providers to educate pregnant women about the signs and symptoms of PPCM, whether it's rare or not. Just because they're pregnant, they just need to know that, hey, it's a pregnant condition. It don't affect everybody, but it's just something you just can be on the lookout for. It's the same signs as pregnancy signs. You don't know, so that could just be something on there that mom's mind, like it was with my sister dying out of nowhere, but hers went undiagnosed. I just knew it was heart complications after she had a baby. So hello, I'm going to be thinking like that. My mind is going to be looking out for that. And so the moms at higher risk should be evaluated and pass the BH Let's Talk PPCM, or the screening questionnaire, sorry, to rule out PPCM. Healthcare providers, should closely monitor the women who are at higher risk for PPCM, such as those with a history of heart disease, preeclampsia, or multiple pregnancies. Monitoring should continue in the postpartum period. We had one mom who she was interested in getting her BNP blood test done, and so we had assessed her. We did the screening questionnaire with our nurse practitioner. We made sure we got her BNP blood test done. What we did see was a little increase that we saw after checking. I think she was checked we did it 2 times. So we did it while she was pregnant. It was like 50 something, and then it increased like to the 80s when she got after she had the baby. So we did it at probably like 2 weeks postpartum, and so like we've been trying to get more moms interested as far as like enrolling in that part of our project that we're just trying to see. We just want to see where that gap is is being held at. So to interrogate the BNP screening questionnaire into the routine of practice for pregnant and postpartum women. So this is what we've been practicing with our healthcare professionals that we have been able to partner with, just to see, exactly what we can do. The questionnaire consists of like 10 questions designed to assess the risk of PPCM in others. Oh, someone say something? The 10 questions are designed to assess the risk in the PPCM others. So it's a scoring system, basically like, normal other surveys that you have. The questionnaire have a scoring system where each question is assigned a certain point value based on the relevance of to PPCM risk. The doctors can use the scoring system, or birth workers, to calculate the total score for each patient. So like a score of 35% is what we're seeing can be more notated as a red flag, because possibly it's just maybe to kind of keep a little eye out on that mom, just in case, to make sure she's out of the clear after she's at least 6 months, not 6 months, 6 weeks postpartum. And so then you have the doctors that need to understand the interpretation of the questionnaire results as well. So like we do have another screening questionnaire training that we have for other providers that we've been helping with midwives on. So we've been able to connect with a few midwives and birth workers on that, and doulas as well, as far as having them trained under the PPCM workshops that we offer. So a certain percentage of the score thresholds can be set to categorize the patients as high risk or low risk for PPCM, and patients scoring above this threshold would warrant further evaluation and monitoring of PPCM. And you can find out more about that on our website, which is there, Let'sTalkPPCM.org. And we have a lot of things that you can actually look into and see exactly how we're going about trying to get this stuff, get mom saved. The main thing, we're just trying to save lives here. Okay, so our support and resources, obviously, we know is a big and important part as far as like once a mom is diagnosed, a lot of doctors don't really know how to um, have an what you call that, like an emotional connection as far as like with the patient, because we know that doctors see a lot of patients during the day. And so like as another thing on the Let's Talk PPCM, we have the empathy. We like to empathize with the healthcare provider on who's actually treating us, as well as not as far as like getting attitudes and having negative vibes and stuff like that, because obviously no, it needs to be a connection, a healthy connection that we, see that needs to be shared within that experience. But obviously, if our doctors is going through a little bit too much, or, maybe they're going through things at home and they have to still come to work and have to deal with everything, that's going on within their workplace. So that can be a lot. And, we also on the patient's end as well, you just get hit with this dreadful condition, and now you just want somebody that to try to understand and that can relate to you, that needs to help you mentally. And so we have a highlight the emotional and psychological impact of PPCM. So that's on patients and their families, to provide information on support groups, counseling services and resources for coping with the challenges associated with PPCM. So basically passing the torch. So once a doctor see that they have a mom who's, dealing with this dreadful condition, hopefully we'll have a magazine there in their office that we was talking about earlier, that they can kind of have somewhere to pinpoint these mothers, so they can feel like they do have a support system they can go to, they can follow up under, so they won't just feel like, oh, my, doctor just threw me off to the wolves and made me feel like, because we hear both sides, so, obviously, right? Like we hear the good side, we hear the bad side. So it's like, okay, how can we fix that? And we're just trying to make sure we're able to, again, bridge that gap as well. So we also want that the fostering of a sense of community among attendees who may have experienced or been affected by PPCM, and provide networking opportunities for individuals to share their stories and support one another. Again, it's an office what we offer under the organization, and we do believe that the screening questionnaire, that it's not just acquiring an acquiring tool, but to actually become a part of a larger movement to raise awareness about PPCM and contribute to its early detection, on helping our healthcare providers and birth workers as well. And the doulas have been wanting to learn more about it as well, because obviously obviously they're surrounded by this mom, all the time. Like, we're able to keep connections on them and seeing how they're coping with day-to-day life, then up to like 6 weeks postpartum, we're still checking in on them. We're trying to see, what's going on, how they feeling, and then some moms, they keep it in a shell. They don't know how to discuss that. Oh, well, I'm really feeling this little pain in my chest, but I think it's from the pregnancy or from, they're not going to say certain things like that. They're going to just, oh, no, I'm okay. I feel fine. So we just have to try to figure out how to, that's what we're trying in the midst of trying to figure out how to best connect with the moms to make sure that they're still aware and caring of what, they're dealing with and what their body just went through. Okay, so that brings us to this rapid and uncontrollable changes. It's a movie that it's called Old. I'm not sure if anybody saw it, but I definitely recommend just watching it because it was something that I thought about when my doctor had let me know about something with my heart. So the PPCM, we know that it leads to rapid and uncontrollable changes in the heart's ability to pump blood effectively. So similarly, the characters in Old experience an accelerated aging process beyond their control, with each hour on the beach equivalent to the years in their lives. And so each hour basically was like another year that they was alive, because they was doing it to actually test their organs to see like if certain medications would work. They didn't know that they was a part of this weird science experiment, but it was a science experiment on testing how rapid their organs can basically give out. And so this brought my attention. My doctor has said basically a woman, with a cardiologist, he was saying basically once a mom is diagnosed with this heart condition, PPCM, the ejection fraction, it ages rapidly. So he was like, my heart was, even though I was a 23-year-old young woman diagnosed with this dreadful condition, he said my heart was like, it was working year old person, an 80-year-old man, definitely basically rapidly aging. We're only 4 weeks postpartum and some really bad, really quick. So that's just another thing. So, a young woman's heart can go from healthy to old within weeks or even days. And so we just want to make sure that they're aware and educated whether this condition is considered rare or not, because we don't know who's carrying the trait. Okay, so we know that multiple disciplinary care is very important, that we've been seeing in the healthcare, as far as like obstetricians, midwives, MFMs, and cardiologists being able to have a teamwork process going on here, to combat the rising rates of heart disease, particularly in younger women. Cardiologists are partnering with their gynecologist colleagues to identify women at key life stages where heart risk factors may become apparent, and anxiety and stress during pregnancy itself, or the postpartum period may contribute to hormonal changes, which we're learning as well, or what Dr. Fett has brought to our attention, that hormonal changes and increased strain on the cardiovascular system, potentially influencing the development or the exacerbation, sorry, of PPCM. So we're seeing that obviously, high stressors, high anxiety can also increase, more as far as bringing those symptoms to the forefront. Me, I was, concerned about, oh my goodness, I don't know if I'm going to go through what my sister went through, because we don't know exactly what she went through. But just that thought on my head, but other women not going to ask their doctor, hey, can you check my heart? That's just not something that you're going to sit there and look at your obstetrician and say, so but me, I already had experienced something like that was very touchy to my heart. I mean, to my life, to make me ask that question. So that's another thing, another reason I love being a doula and being able to just kind of see exactly how the conversation works in the room. Okay, so we have where we wanted to have like genetics test heads up. So like we know that a lot of doctors and a lot of the healthcare providers or people that's trying to do data projects on our PPCM bombs is basically telling them that they should get genetic testing. And so we wanted to bring attention. I always like to tell the moms, because they like to come and ask, hey, have y'all got genetic testing done? So we just wanted to make sure that they are aware, because they're not being told that if they have, let's say if they want to have an insurance policy to be able to cover, and even like with health insurance, whatever it is, like with their the underwriting experience. So insurers may reserve the right to adjust the premiums based on new information about the policyholder's health. If an individual undergoes a genetic testing after purchasing a policy and the results indicate a higher risk of something, even with their kids, the insurance company may adjust premiums accordingly, or they can either cancel them altogether. So the genetic testing may also provide information about the individual's family history or certain medical conditions, and the insurance companies often consider family medical history as part of the underwriting process. And if there's a higher risk, then it can impact the premium, or it can impact them all together as a family. So we just wanted to make sure that moms are aware that, okay, if you do go into the genetic testing, make sure that you have some type of policy that where you're able to be protected, covered, so it wouldn't keep them from getting treatment later on, or having expenses to be able to afford those treatments. We've been seeing a lot of women who not able to have the money to get the medications that they need, and Tresto being one of the main medications that they're using right now to help build that heart function back up. I know that it helped me a lot in my healing process, and Tresto was one of those medications that just helped increase that heart function really quickly, but it took mine, I think, 2 years. And so that, with that being said, we just want to make sure women are aware of that. Okay, so this is something we have outdated, and if you can even see that, it got outdated right there, highlighted. And so this is, I believe, something was pulled from about 2011. So where they were saying, as far as like the relative levels of the incidence with PPC. And so they were seeing around that time frame. And so that is where we bring in, actually, we have been partnering under a PPCM registry. And so we're going to be hearing a little bit more into details about that. And so we just wanted to make sure that we're up to date on as far as the data, because a lot of doctors, a lot of nurses, the students, they need to know exactly where we're at with this thing. And so we just need to want to make sure kind of that we're putting, like I said, bridging the gaps in these the parts that we're saying that needs help. Okay, so next we have, we'll be discussing with Dr. Sarah Thordsen. Dr. Sarah Thordsen, she's an assistant professor and cardiologist at the Medical College of Wisconsin. She has a special interest in heart disease and complicating pregnancy, especially peripartum cardiomyopathy. She's involved in a clinical program developed including surrounding cardio obstetrics, medical training, wellness, and cardiovascular imaging. So PPCM org.org from ppcmr.org is an online research registry for PPCM survivors, and they aim to prevent, treat, and cure PPCM through education and research. So I thought that would be very important for our moms, and then just for other healthcare providers to be aware of as well, because we need to know exactly where to send, these moms when they do get hit with this dreadful condition. So with that being said, I'm going to go ahead and get the floor over to Dr. Thordsen, and give me just a moment.
Thanks for I can share my. There we go. Is that better?
Yes, ma'am.
Okay, very good. So good morning. Thank you for the invitation. My name is Sarah Thordsen. As Brianna said, I'm a cardiologist in Wisconsin. And I have a special interest in cardio obstetrics. So women with heart disease relating to or prior to a pregnancy, and a special interest in peripartum cardiomyopathy. And I've been really lucky to work with Brianna over the past probably 2 years through both her organization, LetsTalkPPCM, and our research registry, PPCMR. And so I'm going to share a quick, probably 20-minute update on some questions that Brianna asked me ahead of time on PPCM. And then I'll take any questions that I can answer to the best of my ability. So here we go. First, PPCMR was developed in 2019, right before, as I fondly call, the zombie apocalypse, or COVID-19. And it's a research online registry for PPCMR survivors. And Brianna has been kind enough to get involved on our advisory board And I'll talk a little bit more about how you could get involved or refer folks to get involved later. So let's talk about what is PPCM. And I get this question a lot. Did I have PPCM? Does my friend have PPCM? What is PPCM? And I'm going to tell you that even amongst doctors, that really depends on who you ask. The working group for the European Society of Cardiology has the definition that most of us adhere to. And definitions are important, not because it is the source of all truth, but just because when we do research, we want to include the right people so that we know if our interventions or plans have the outcome that we desire. And so this is the definition that most of us reference, at least. It's the development of cardiomyopathy, and cardiomyopathy is a big word, essentially meaning heart muscle dysfunction. But in this context, I ask my patients to think about it as heart muscle weakness. So the development of heart muscle weakness in the last month of pregnancy or in the months following delivery. And so as we discuss sometimes, what's different about the last month of pregnancy or 5 months, 6 months, 12 months after pregnancy? There's not a line that's drawn in the sand that's different for women 31 days before they deliver or 5 months and 1 day after they deliver. And so some of this has to be taken with a little bit of your best judgment. But it's the absence of another identifiable cause of heart muscle weakness or cardiomyopathy. And I'll talk about that because that also is somewhat changing in our conception of what cardiomyopathy, peripartum cardiomyopathy means. And now this is another area of contention, but a heart muscle function, what we call left ventricular ejection fraction or LVEF, of less than or equal to 45, with or without heart muscle dilation. So your heart doesn't actually have to be enlarged to have this diagnosis. It can be normal in size. So one of the questions I get a lot is, what happens if my ejection fraction isn't 45 or less? Did I still have PPCM? And Brianna talked about that in her initial PowerPoint, that when she was first screened, her ejection fraction wasn't less than 45. Did that mean that she developed peripartum cardiomyopathy later? Or did that mean that she was already on the journey to develop that? And I'll talk about that a little bit more. So let's talk about the symptoms of heart failure. So I said cardiomyopathy means heart muscle weakness, okay? That does not mean to a cardiologist necessarily heart failure. Heart failure is a combination of symptoms, a clinical set of symptoms indicating that the heart muscle is not performing its function well enough. And that's heart failure in a nutshell. But the symptoms of heart failure are shortness of breath, swelling on your legs, an inability to lay flat, coughing, and swelling of the legs and feet. Now, I'm not sure how many of you who are here today have been pregnant, but some of these symptoms have significant overlap with symptoms that women experience sometimes in their third trimester. And so this, I think, is one of the most difficult parts for cardiologists, obstetricians, birth workers, whomever is working with these women. This is a hard thing to tease out what is not normal in the end of a pregnancy and indicative of something more serious. But if you're asking about strictly the symptoms of heart failure, these are them. So what happens if your pump function isn't less than 45? Were you not affected? Do you not need medication? Does this community not include you? And I think that really depends on who you ask. That depends on who you ask, even amongst cardiologists. And even amongst cardiologists who specialize in treating peripartum cardiomyopathy. So the kind of general opinion right now, although this is not in a guideline statement, is that people or women who have a higher ejection fraction, 45 to 50%, let's say, but have typical symptoms, may be included in that diagnosis. Again, this is not in the guideline statement yet. And just for reference, what is a normal pump function for women? some people will say, oh my gosh, I'm only at 50%. Normal for women depends on what test you're doing. So are you talking about a heart ultrasound? Are you talking about a heart MRI? Are we talking about, another kind of study? Most commonly and most available in this country is heart ultrasound, also called echocardiography. And the normal for women for echocardiography is 54 and above, okay? So your heart is supposed to pump out at least 54% of the blood in its chamber every heartbeat. So that's the kind of reference point. So then let's talk about how common this is, because Brianna had a lot of conversation about this being rare. Is this a rare disease? Well, that depends on what the diagnosis or what the definition of rare is, and honestly, where you are in the world. And as you can see, this is the incidence, so number of women diagnosed with peripartum cardiomyopathy per 100,000 births. And it becomes significantly more common in certain areas of the world. So India, Pakistan, Haiti, and Nigeria all have significantly higher numbers of women per the number of births being diagnosed than, say, Sweden, Denmark, Japan. And why is that? Well, that's a great question. That's a question that we've heard talk about at conferences, on this subject for years now. And it probably is due to a number of things. One, there's differences in how women with these symptoms are diagnosed and evaluated. So wherever you are in the world at the time you're having these symptoms, there's a different set of tests that may be considered standard. Two, that there are differences in access to care. Depending on your socioeconomic ability to seek care and sometimes seek specialty care, that may influence how likely you are to be diagnosed. And three, there's likely a genetic predisposition influencing these rates also. So in the US, people ask me this all the time, how common is peripartum cardiomyopathy? Well, it probably, the commonly quoted number 1 in 2,000 probably underestimates the incidence of peripartum. It's probably nearer to 1 in 1,000 or 1 in about 1,200, depending on the set of data that you look at for reference. So Brianna talked about risk factors that they found associated to peripartum cardiomyopathy in their NT-proBNP project. So I included risk factors that have come out in multiple scientific studies, and you'll see a lot of them are the same, right? She's seeing in her data set similar things to what large worldwide data sets have seen. So we talked about age greater than 30, absolutely. Being of African descent, absolutely. Pregnancies with multiple gestations, meaning twin, triplet pregnancies, for example, and having had multiple pregnancies. So having had at least 3 prior babies, or this is your 4th pregnancy. And then the big one, as she talked about, concurrent or prior, preeclampsia, eclampsia, or postpartum hypertension. Huge, huge increase in risk. And we used to think that they were 2 separate things, 2 separate disorders. And now some people talk about hypertensive disorders of pregnancy and peripartum cardiomyopathy, maybe existing on a spectrum, okay? Maternal cocaine use, gestational or chronic diabetes. And then there's always been this question about selenium deficiency, which is a mineral in the role of peripartum cardiomyopathy. So now this is the big question. What causes PPCM? And I think if I had an answer to it, I would be very famous. But I don't think that the answer exists, and I don't think the answer is the same for everyone. And that's what I'm going to start with. But I'm going to tell you, in my opinion, what are the most plausible biological explanations, and then we can talk about kind of the other things that come along. So the one thing that most of us who study this disease agree with is that there's an imbalance of hormones or chemicals that are secreted during the pregnancy. And hormones are anything that has an activity that's secreted into the system. So we think about hormones of pregnancy being like estrogen and progesterone, but there's a whole plethora of other things that are secreted from the placenta and from other parts of the body during pregnancy. And one of the things that secretes hormones is the placenta. And very late in the pregnancy, the placenta starts to secrete things that constrict blood vessels and actually can damage the lining of the blood vessels and cause inflammation. And so one of those hormones or chemicals was referenced by Brianna, SLIT1, which has gotten a lot of research, but that chemical actually can impact the blood vessels. And so when there's too many of this type of hormone in the body, that can put someone at risk for peripartum cardiomyopathy. The other thing is hormones secreted from other places, like the pituitary gland, which is in your brain, kind of right behind your eyes. It secretes a lot of hormones. And the one in the kind of question here is a hormone called prolactin. And we most often think about prolactin when we talk about lactation and breastfeeding in women. But prolactin, as it's filtered out and broken down by the body, one of the smaller fragments of that prolactin chemical or hormone can actually also have qualities that damage blood vessels. And so if these damaging chemicals or hormones are present in too high of a quantity, and the other hormones that counteract them are not present in a high enough quantity, then we have vascular or blood vessel damage. And so that in and of itself is one of the kind of theories or hypotheses that relates to why heart failure or cardiomyopathy happens in pregnancy. So this is a drawing from, I'm sorry, I don't have the citation on here, but essentially when we have these hormones or chemicals that constrict blood vessels or damage blood vessels, some of the arteries or blood vessels in the placenta can start to become smaller, and then they have decreased blood flow to the baby. We get hypoxia, and then we get the whole kind of series of preeclampsia or other syndromes of placental dysfunction. So that's kind of the downstream effect of the imbalance of pro-blood vessel versus damaging blood vessel hormones. What about genetics? Everyone talks about a genetic predisposition, and yep, genetics definitely have something to do with it. And in PPCMR, our registry, two of the other, our advisory board is made up of two other physicians, cardiologists, both from University of Pennsylvania. And one of them has a specialty in genetic research. So Dr. Zoltarady has dedicated most of his career to the study of this. And he thinks right now that probably 15%, maybe a little bit more, of women have a genetic predisposition to develop cardiomyopathy or heart muscle weakness. And the most common genetic abnormality that he's found associated with this is an abnormality in a protein, or again, a part of our DNA, or I'm sorry, a part of the heart muscle cells themselves called titin, which is a big protein as it is, and it helps the heart muscles contract. And so that's the most common abnormality that he found, but there are others that are associated with heart muscle weakness in pregnancy. And interestingly, not everyone who has this protein genetic abnormality has PPCM. And so, it's not necessarily 100% of women that have this will develop PPCM, and we don't really know why that is. So this is an example of some of the education that we have on PPCMR. It's free, it's on our public-facing page, and it summarizes the most recent sort of information that we have at the time we make it, at least, about a specific topic. So this is our kind of handout or flyer that can be referenced and used on genetics and PPCM, and we offer it. So the next kind of thing that we talk about as a potential cause of PPCM is the immune system. And we know that our immune system fights the kind of sicknesses and illnesses all the time. That's what we think about. But it also is constantly working to to figure out if there's things invading our body. So like bacteria or viruses are the example, but also if cells from another person that don't have your specific cellular makeup on them, your immune system can see them as not of your own body. And so sometimes fetal cells can escape into the maternal circulation and sit there and not be rejected as they normally would have, because our immune systems are slightly weakened in pregnancy. And if these cells lodge, let's say, in your heart muscle, they could trigger a pathologic immune response. So there's some thought that that has some role in contributing to certain women's presentations. So what about others? Inflammation. And this is what we saw in COVID a lot, that the whole body system became inflamed, and that damages most commonly in COVID, at least, the lungs. Viruses and other things that can cause heart inflammation, that's called myocarditis. And then again, this selenium deficiency, which is a mineral sometimes found in the soil. But what we are now talking about most often at our scientific conferences is that PPCM is likely the combination of a specific predisposition. So let's say pre-existing heart muscle weakness, a genetic abnormality, etc., and the stress of those, the end stage of pregnancy, those hormones or blood chemicals causing an imbalance in the damage to the blood vessels. So the pregnancy is a stressor, and for some reason, the woman has a predisposition. Now that's not proven yet, that's just something that we're all thinking about, because the women who develop PPCM are, as I said, different. Only 15% of them have a genetic variant that we can right now find. And so what if all these other things are causing a certain group of women to be at risk, and the pregnancy stress is just making some of their heart muscles weak? And so that's kind of what we're talking about. And we call that in science the second hit hypothesis, meaning the first is the predisposition, the second is the stress in the pregnancy. So then we need to talk about something that I think is very important, and it's that Black women are not only more likely to develop PPCM in their pregnancy, but unfortunately, they're being diagnosed later, and their outcomes are not as good as non-Black women. And that's probably a result of several different things. Dr. Louie, who is another one of my co-founders of PPCMR, wrote about this in 2020, and about the importance of an early diagnosis. And so these are two sets of charts that I just want to show you quickly from her paper that she wrote. But in Black women, the black bars are having preeclampsia, high blood pressure, or eclampsia, so a hypertensive disorder of pregnancy, and the gray bars do not. So you can see that overall, most Black women are diagnosed between the first week and 5-ish months postpartum. And if you look at the overall curve for non-Black women, they're being diagnosed in the first week following their delivery more commonly than they're being diagnosed in the 5 months after. So they're being diagnosed earlier. The other thing is that we know that being diagnosed earlier is better. And that's probably because of access or earlier kind of medication management or things like that. But being diagnosed early, regardless of being Black, not being Black, and for the whole cohort, being diagnosed early is more related to a complete recovery of your ejection fraction, or that heart muscle pumping function. So let's talk about the role of NT-proBNP. This is meant to be a big question mark, and this is a study that I would like to really do someday to answer the question: is who should we screen with NT-proBNP, and then at what gestational age? So should we screen you at 12 weeks or 24 weeks or 32 weeks? And should we screen you only if you have a risk factor, or should we screen everyone? Or should we only screen you if you have symptoms? I think those questions from a scientific standpoint aren't yet answered. But it is important to know that normal depends on the test you're using, so be very careful to look at the normals for testing. And also there has been a bit of work done on the normal in normal pregnancies. So be aware that that is different depending on the time you're looking at in a pregnancy. So what do we do to manage women who are found to have peripartum cardiomyopathy, or really at this point, any cardiomyopathy in pregnancy? Unfortunately, for the mother, some of the medications that we use are not compatible with pregnancy. So the things that we do for you if you're diagnosed during your pregnancy are we try and optimize both your blood volume and your blood pressure to keep the work on that weakened heart muscle as low as possible. And if the baby or the mother aren't getting enough blood, then you need to be in the ICU and have ICU level support. And that's a whole nother kind of discussion on what that is. We try our best to optimize, meaning to make the mom's blood pressure, blood volume, breathing as good as possible before we deliver a baby. But if your health or your life or your baby's health or life are at risk, then the delivery is done emergently. So then I get this question a lot: how should I be delivered if I have heart failure? And I'm going to say, as Brianna said, that this talk is not meant to be a acceptable replacement for a conversation with your doctor or provider, because in reality, your specific risk, there's no way that can be covered for every single person. But for the most case, vaginal delivery is safe from a maternal heart standpoint, as long as you're what we call optimized, meaning your breathing, your blood pressure, your blood volume are optimized. As a whole, C-sections done just because you have heart muscle weakness, presuming that you're stable and safe and your baby is stable and safe, are associated with more complications for moms unless you're not stable. So that's a very big caveat. They're often done because of the health and safety of the baby. The baby isn't tolerating the weakened heart muscle. The baby isn't getting enough blood. So I'm not saying that every pregnant woman should have any type of one delivery of the other, but to say that if you're optimized, we think now that you don't necessarily need a C-section. So what do we do in terms of timing of delivery? Should you deliver early? Should you deliver when at 40 weeks? Should you deliver when your body tells you to? And I think this is, again, a conversation between you and your provider. In terms of what we do, it really is a risk and benefit conversation. How safe are you? How safe is your baby? And what does being pregnant for longer mean in terms of risk to you and your baby, right? And so that's, your doctor gets to have an opinion about that, or your provider, and you get to have an opinion about that, and then it is what it is. We typically at, my practice is to, if women are stable and safe and their babies are getting enough blood and they're getting enough blood, to try and keep them pregnant to 37 weeks. But if not, as I said before, your health and safety and your baby's health and safety matter. So once you've delivered and the pregnancy is over, what do we do? How do we get women to that normalized heart pumping function again? And really, it's something we call guideline-directed medical therapy, or GDMT. You'll see that abbreviation a lot. And so this becomes a little bit tricky and needs a conversation also, because some of the medications that we use are, number one, unfortunately, very expensive in this country, which I think is a travesty. Number two, some of them are not used in breastfeeding, and this is constantly changing, okay? So the medications that we use are of 4 main drug classes, and they work together to restore heart muscle strength. And ideally, in the ideal world, women would be on as much medication as they can tolerate of these 4 classes. Now, until very recently, most lactation consultants and pediatricians were not recommending breastfeeding with Entresto. That's changed somewhat recently. And so I think that needs to be a conversation with your pediatrician and lactation consultant, because as Brianna said, Entresto can have very significant impact for good on the heart muscle. Metoprolol or any beta blocker that we use for heart failure is typically considered reasonably safe in lactation, except for certain beta blockers that go through the breast milk more commonly. And so that's a conversation with your pediatrician, but there are some that we can use. Spironolactone is a medication that, as long as your baby is full term, most lactation consultants and pediatricians will be okay with. Currently, a class of medications called SGLT2 inhibitors, or Farxiga or Jardiance, you've maybe seen them on the TV, are not used in breastfeeding. So those are things that need to be discussed individually with your provider and pediatrician lactation consultant. Then there's the question about bromocriptine. And bromocriptine is a medication that blocks prolactin, that blood chemical or hormone that I talked about in the beginning. There's a study ongoing about this. And then there's a question about who should be on blood thinners. Blood thinners prevent blood clots. This is an area that's under debate. And so I think that's something that should be discussed with your provider. That's all I have today, and I'd like to end with a slide about PPCMR. It is, as I said, an online registry, and it's a site where you don't need to be referred by your doctor. You can take yourself to the online registry and sign up and do the consent process and fill out some surveys for us that will really help us understand more, not only who is being diagnosed in this country, but how they're being treated, and eventually to prevent, treat, and cure PPCM so more women don't have to suffer. So that's all I've got for today, and I appreciate the opportunity.
Thank you, Dr. Sarah. That was beautiful. Lots of information, even stuff that I've learned today. So, oh my goodness, love it. And that is definitely important. It's like, yeah, a lot of, I think what we've been experiencing is definitely input. And I'm just glad that you all are, was able to even come up with the idea to be able to offer this for the survivors. It's just we're trying to make sure we're able to get them interested on their end, and we have to see why it's an important process for us to engage in. So definitely trying to see how we can encourage more survivors to get involved with the survey. But I'm thinking maybe implementing in the with the magazine, what we're trying to do, being able to have as much information as possible, so we could definitely be able to have something in there so moms can be aware. So we're gonna definitely be seeing how we can implement that and help
Can
you
I ask
all.
Dr. Thordsen a question?
Oh yeah, we had Q&As. Let me see, because we have another speaker. So, is it something that's like urgent, or can it be something like wrote down and we can discuss it a little bit in a few minutes?
Sure.
Okay,
I
okay,
can send
thank
it to you.
you. Oh, okay, okay. Let me see. I've learned as far as the family occurrences about the studies, and that had indicated a familiar occurrence of PPCM, suggesting a genetic predisposition. Um, and if a woman, has a family history of PPCM, especially in first degree relatives like her mother or sisters, it may increase her risk of developing the condition. And as I was talking about with my sister right there, and then versus us, like if we were what's being able to do this on the genetic test. I'm not genetic testing, but the BMP blood testing, as far as the program what we're trying to do, that maybe it could have saved my sister's life, but unfortunately things the way it happened backwards, and we had to lose her in order to kind of see exactly how we can help prevent that from happening. So now her beautiful children is just growing up without her now, and they are it's been 10 years now since she passed, so you can imagine how big they are now. So certain genetic variants or mutations that may contribute to an individual, and the cardiomyopathy. We don't want to scare moms as far as like trying to make sure, trying to figure out how to spread awareness without creating fear. So a lot of women are, they don't feel like they're going to go through a lot of things and I was one of those women. I was like, ain't nothing wrong with me. Ain't nothing going to go wrong with me. I ain't doing, I wasn't thinking anything wrong. I didn't want anything to be wrong. Just because it happened to my sister don't mean it was going to happen to me. Right. So like, and it did, it turned around and happened right to me. I have fell into the exact same symptoms that sent her to the hospital. So the genetic factors are definitely important and associated with the cardiomyopathy. It may influence the development of PPCM, for women that just unaware and don't know if they have it. So we already discussed that as far as Dr. Sarah, so we don't have to get too much on that. The immune system and the inflammation, and then the hormonal and the genetic interplay. So thank you so much, Dr. Sarah, for going over this part for us. That brings us into Dr. Reed's, Dr. Amy. Let's see, Dr. Amy Raines is took out the first name of there. And we want to be able to discuss her expertise in the maternal and child health. Her academic background is in the area of social work and public health. Her community based research and interventions focus on pregnancy, birth, and maternal health outcomes and women's preventative health among vulnerable populations. She is a director of the UNT Health Science Center Healthy Start program. For what is that? It's a federally funded intervention to reduce perinatal health disparities, and she's an appointed member of the Texas Department of State Health and Services Maternal Mortality and Morbidity Task Force. And with her is Dr. Tania Lopez that will be speaking with her. This Dr. Tania Lopez is a midwife, and I don't know if I added the extra slide in here because I was trying to see how to implement that together. And are you both ready to speak?
So I'm taking a little, I really appreciated that both of those presentations. I learned so much from Brianna, and now with Dr. Thordsen, really filled in some gaps, but it also opened up some questions. There's just so many mysteries that are yet to be figured out about this condition and women's health in general. I'm going to take an approach. So I have been serving on the Texas Maternal Mortality and Morbidity Review Committee. Started out as a task force, but now it is a review committee for the past 10 years. So I have read, and I also have a contract that we prepare all the maternal deaths in Texas for review, which includes redaction and abstraction. So I've read hundreds now of the worst possible outcome, right, of any kind of condition that happens during pregnancy, which is maternal death. So I'm going to talk a little bit, and these are my reflections. They are not anything that's in a report, although there's some overlap. This is just really, if someone were to ask me, well, what can we do, or what's going on? This is a very broad perspective of what I think that we need to know, and women need to know, and partners need to know. And so I'll go ahead and get started. So I have just some 5 points. One of the things that really strikes me when I'm reading some of these cases, and we don't necessarily have information about who's in the room. Sometimes we do, but they're from medical records. And something that I've gleaned from reading these and reviewing these deaths is that the importance of pregnancy and postpartum period is not a time to retreat to yourself. It's a time when to really mobilize and harness all the resources that you have. So having those well-informed advocates, loved ones, and partners all the time with you. So the reason I say that is to be in the prenatal care period where they're supporting you, but they're also another set of ears listening to what the provider is saying. So you have a better idea of, we can converse together after the appointment and then share what you learn. And then if there's some gaps, you can seek more information from your provider. But having someone there with you is really important. That's why I think the role of doulas has become so over the years more popular, as people realize sometimes husbands and partners, they're well-intentioned and they're there for support. You need them, but they may not be necessarily listening in the same way that someone that is trained as a doula might be listening. And I would also say that having not to be alone, and it's not to scare, it sounds kind of scary now when I look at the slide. It's not to scare, but it's just this idea that, again, community, family, support is so important during this time. To gather information, to be bringing books to the pregnant person, to bringing information. And this should occur during prenatal care, labor and delivery, and in the entire postpartum period. we in our culture don't do a good job about supporting the woman or the birthing person after they have given birth. And I've had the fortunate work experience of working and personal with volunteer work of working with people from other cultures, and I think other cultures, not all, but many other cultures do this really well, where the pregnant woman is really cradled herself during the postpartum period. And I think if we had that more, we had an opportunity to address some kind of things that might not be going right. The tendency for women to downplay symptoms that they have, having someone there to say, no, let's go check it out, and really encourage them to go to the health provider. The second thing that I have really come up with is that, you know, pregnancy, this sounds so simplistic, but it doesn't happen so often. We still hover around, it's gone down a little bit, but we still have around 50% of pregnancies that aren't planned. But planning pregnancy allows you to receive all the kind of care to get yourself in the best optimal shape before you become pregnant, to make sure that you have access to care to manage health conditions that you know of. Genetic counseling is an underused resource that's so important, and we talked about genetics here. In knowing your family history, as both speakers have talked about, that the need to really know that information, and this can all be achieved through planned pregnancies. Ideally, everyone would be healthy and knowledgeable, and so if a pregnancy occurred, it wouldn't matter so much. But we know that unplanned pregnancies are associated with poor health outcomes. The third thing would be just be aware that not all care is quality care. There's some really good providers. And one of the things that has stayed with me of being on the committee, being a non-medical member of the committee, is the medical doctors that will shake their heads. And some we've witnessed over this 10 years period, even cry at the kind of care that they've seen happen. And it's important to know about the provider that you're going to. I always joke, although it's not funny, that women know more about the restaurant down the street than they know about that hospital where they'll be delivering. And gathering as much information and things that are important, like quality of care, not necessarily. I know for a while we had one hospital where it seemed like, I say everybody, obviously everybody can deliver there, but it seemed to be the popular hospital. And then when another hospital started to really expand, people talked about how much nicer the rooms were. And so that's, you know, that's important, I suppose, but there's other important factors. They're not easy to find out about hospital quality, but that's something I think will be changing over time. So there is a need for quality improvement. We know that. It's shopping around for that best care, asking about quality of hospitals and physicians. One of the things that we see overlooked is risk assessments of women. We see no indication that any kind of assessment was done. Also, that social services and screening and referral for social determinants of care is underutilized. So looking at those non-medical drivers of poor outcomes is really important when working with women, especially vulnerable women. But I think all assessment should be done, social determinants of health assessment should be done for all women. And then another thing that I witnessed through reading these records is just the lack of coordination of care. That goes back to needing, not being alone, having support people with you that can help coordinate that care if it doesn't exist within the healthcare system itself. Ideally, the care coordination would occur through just really good systems of care. And some systems of care are really good, but others are very fragmented. I always remember this experience of my sister that delivered in a women's hospital in upstate New York. And I have never seen anything like that in my life. So fragmented. It was so fragmented, I couldn't even figure out what was going on. And that was in the hospital with a high-risk delivery where she shouldn't have delivered at that hospital. Had I known then what I know now, I would have never allowed her to deliver in a hospital that just wasn't prepared for her previously known health conditions. But seeking out additional services, having that support to seek out additional services if it's not part of the healthcare system itself. So this is specific to Texas women, but this is probably true, as I've read from other review committees across the country, is that women are really, a lot of women are suffering. There's mental health conditions that are being not addressed and under treated. Substance use, we see many opioid, well, not just opioids, but other kinds of substance use overdose deaths. And then we see women dying in the pregnancy period and the postpartum period for reasons related to the pregnancy through violence. And number 5, I would say, though, I wanted to point out that there is reason for hope and there's room for change. We found that 90% of the deaths that we reviewed were preventable. It's important to have public awareness, like what's happening today, thanks to Brianna, and other kinds of activities that are occurring. There's much more attention to maternal health and wellness and interventions, and it's so exciting to see that happening. And the need for health promotion, the need for, you know, it's so important. We talk about pregnancy being this stress test, and that could identify health problems, but also I guess what I'm saying is that the need for women to be healthy before they become pregnant or know about their health conditions and have them managed. And we need much more health promotion for that to occur. So this is just 5 points, just some reflections that I wanted to share today that could be helpful to people that are navigating healthcare systems or thinking about pregnancy or are pregnant themselves. So thank you for this opportunity to share this information with you today.
Ready to hear this. Thank you so much for joining us today.
Yeah, I just, you know, a lot of the things that I had to say are very similar, but I'm coming at it from the nurse midwife angle.
Absolutely.
And I thought maybe we could talk a little bit about, I mean, we've talked about the risk factors. Dr. Thordsen kind of went through all the pathophysiology. I did want to talk about, you know, about how racism, systemic racism, structural barriers, institutional barriers, all these things affect women of color who we know have higher incidence of this disease. And so I think it's really important to address those issues in the institutions and in the healthcare systems where we work, and to know that it exists. And, you know, we're trying to educate ourselves that it exists and we're trying to change it, but, you know, it just takes time and it takes persistence in doing that. Also, I wanted to talk about the social determinants, which have been brought up a couple of times, but, you know, those things affect our circulatory system, they affect our heart, they affect our mind, they affect our physical, what we eat and how much exercise we can get in our neighborhoods and what food we have available to us. And those kinds of things impact women too. And I think it's important for all healthcare providers to take that into consideration. I really wanted to just talk about midwives and doulas, even friends and family, when you have somebody who's having these symptoms or even after the diagnosis. Like what is it specifically that we can do? Because we know we're not cardiologists. We know we work within a system that we have to refer, we have to consult. And so sometimes, just I was sharing with Dr. Thordsen, sometimes it's difficult to even convince the providers that we're working with that the workup is indicated. In other words, we want to draw blood or we want to get the echo, but the person we're working with or the person or maybe the system we're working in or insurance won't cover it. And so sometimes we have those issues that comes up and make it difficult to work. So, you know, as midwives, as doulas, we're in the rooms with the patients, and we may be the first point of contact. We may be the first one to hear about these symptoms, and listening is really important. A lot of women will talk about their symptoms, or they'll be afraid to talk about the symptoms unless we really ask and we really dive into it. And it's important to get a family history and to advocate. Dr. Raines and I took care of I worked with her in Healthy Start. And one of the things that I found out, which was, I'm sorry, I didn't have my video on this whole time. One of the things that surprised us was we had a client who had, she had a PE, pulmonary embolism, but we didn't know she had that. She was just having a cough when she laid down. She couldn't, like, she could barely breathe when she would lay down and go to sleep, and it sounded suspicious. So we sent her into the healthcare system to be evaluated. And I don't know if they didn't ask her the right questions or she didn't feel confident to say what the problem was, but she ended up going home with no treatment. And we called the ambulance and sent her back to the hospital. And they finally did the testing to find the pulmonary embolism and give her the treatment that she needed. So even sometimes when the patients present for the symptoms, they're not listened to, or they're not assessed, or asked the questions that need to be asked. So I always tell other midwives, I tell other doulas, and I tell family, like, you have to keep being persistent. You have to say what, I mean, we as in the healthcare system, sometimes we have a hard time. We can't read minds, obviously, but even when we hear the words, sometimes you have to ask it in a different way to get clarification on what the symptoms are that they're presenting with or what they're concerned about. You guys did talk about vaginal delivery being safest, and that now breastfeeding is recommended, especially if certain medications are used. So that's something to be sure and tell your friends, your family, your clients as a doula. And so again, the midwife is going to collaborate. We're going to refer. We want to engage with the patient. Just because we refer or we collaborate doesn't mean we just drop them. Like, we want to continue to engage with them. We want to check on them, how they're feeling with their symptoms, and to facilitate the care that they are going to need. This is just a quick slide on assessing for cardiovascular disease, and to remember that at multiple intervals during the pregnancy and afterwards, to ask patients what they're feeling, any new complaints, any new symptoms, and also to, early diagnosis does improve outcomes. And I love the slide that Dr. Thordsen showed, where the African-American women or women of color, they get diagnosed later, and then we wonder why their outcomes are not as good. It's because they're the delay of care. So it's really, really important to make sure that the care is initiated, because a lot of women, they report the symptoms, but they feel like they were dismissed when they talk to the provider. And so the symptoms we've already talked about are dyspnea or difficulty breathing, especially if you walk up a flight of stairs or even across the room. You feel like you can't breathe when you lie down. At night, you wake up with this feeling that you can't breathe, and then edema in the lower extremities, persistent cough, which again, Dr. Thordsen had said that these are symptoms you have in pregnancy. So it's hard to sometimes discriminate. And then there's the atypical symptoms that people may not even associate with that. And then some conditions act like cardiomyopathy. So I was talking to a nurse today who's 22 weeks pregnant. She has had bronchitis very recently, and she's using an inhaler. And she's like, I'm just afraid I have postpartum or peripartum cardiomyopathy because I can't breathe. And I'm like, well, are you taking your inhaler like it was prescribed? You did just have bronchitis. And so just talking through all the symptoms and making sure that nothing else is going on, there's not another accompanying system. I really think that listening is so important. So after the diagnosis, there's this really interesting article by DeWolf. And I don't know if you guys have read this article, but the interesting thing about this is that after the diagnosis, right, we found the problem, we're treating the problem, maybe the patient went to ICU, and guess what? You're feeling better, the symptoms have resolved, and we're just gonna send you home to be off on your own. And a lot of women, they felt anger because it took so long to get the diagnosis. They feel frustrated with the system. They've had to make multiple visits, like the client I sent to the healthcare system 3 times, and they finally found what was wrong with her and treated her, and symptoms are not taken seriously. But some of the themes that came out of this study by Decker were that initially they felt a sense of doom, right? They feel like they're gonna die. They feel hysterical. They feel tortured. They feel like their life is gonna end, and who's gonna take care of my children, or how am I gonna take care of my newborn? It has a impact on relationships. future children, if they want to have more children, how do I move forward? I mean, some of these women were afraid to go to the grocery store. They were afraid to be alone with their baby. And here we are, you know, it's like a NICU baby, right? We put the babies in the NICU because they need a lot of care. And then all of a sudden we send them home with the moms, and the moms are like, well, where are all those monitors that were on my baby? And how will I know if they're having an episode of apnea? Or how will I know if they're gaining enough weight? I don't have one of those scales to weigh them every day. And women with PPCM have the same feelings. They go home all of a sudden and there's no monitoring, or there's no communication, or nobody's measuring their urine output, or, you know, and so they're very, very fearful that you go from all this high level of care to nothing. And so I think, you know, maybe we should consider maybe a rooming in period where women have, you know, a little bit of time of transition away from that high level of care. We talked about that. I don't know if anybody talked about birth control, but it's really important when we talk about management of these patients. We want to counsel them on what kind of contraception they want to use so that they can become healthy and get their heart healed before they attempt another pregnancy, because these women are obviously at risk for being pregnant because they're of that age of having babies. And so a really detailed conversation about what type of contraception is going to work, putting them on something right away, and something that is effective. And also on something that's not going to increase their risk. The last thing I wanted to talk about was depression and how to manage postpartum depression, because any woman that has a birth outcome that she was not anticipating, and especially one that's so serious and critical, is going to change her perception of her whole mother experience. And that's a high breeding grounds for depression. And Brianna, I don't know if you experienced that, but I'm sure if you talk about it with your friends and your family, that you, looking back on it, it was a traumatic incident for you, and you probably did have some depression. So awareness is really important, like Dr. Raines said, and like Brianna said, and just, you know, the shared decision making with the patients, like what is your plan for the future? How can we help you to be successful? What are your goals for treatment and for recovery? And this need for psychological support. Let's see, we talked about the emotional impact. I kind of got ahead of myself before. One of the themes of silence after chaos was what I was talking about, and disrupting early mothering. And then, you know, what is this? How much control do I have over the situation? Everyone else is deciding what's good for me. But how much control do I have? And as women in hospitals having babies, we all know that we feel like we have very little control over the situation. Women who were newly diagnosed have an elevated risk for cardiac avoidance symptoms. So they don't want to do anything that's going to worsen their heart muscle weakness. So they're afraid to even do any activity. And that's probably the worst thing you can do. And so really talking with the cardiologist to understand what the recovery is going to be like and what's expected, and having someone just make a proactive referral. If I think someone's at risk for postpartum depression, I don't wait till they become depressed. I talk to them about it. I say, you're really at high risk. I think having a therapist kind of on standby for you, have one session, and then you can decide later if that's something that you would benefit from. There are medications for depression, even temporarily, to help you get through the stress of that situation so that you don't have long-term post-traumatic stress from whatever you have to go through as far as your cardiac condition. So long-term, you know, the importance of follow-up. I have so many clients with high blood pressure who they don't have a PCP, they only have an OB, and the OB doesn't really want to see them for their high blood pressure. They don't want to treat that, but the patient doesn't think, well, I probably need to see a primary care doctor for that, or they don't have insurance for it. But it's really important. It's like, you know, we really stress pap smears and what to do with an abnormal pap smear, but for these kinds of things, sometimes we just let it, we don't stress it enough, and people don't understand how important that follow-up is, and the annual visits, and especially if you have a family history. Also to let them know that they still can have a normal life with follow-up, with treatment, and everybody has their own individual concerns and individual situations that they need to think about. And so, it's cardiovascular disease is what's killing women. It's a leading cause of maternal mortality. And PPCM is one of those conditions that is included in that. Delayed diagnosis leads to poor outcomes, as we talked about. Women can recover, they can breastfeed, they can have vaginal deliveries, and they can have children in the future if they have appropriate recovery. And yeah, I think midwives, doulas, family members can advocate and try not to just let people minimize their symptoms. And if you don't feel like you're being listened to, keep talking. Like, keep beating on the door, keep calling the office, keep saying I'm just not feeling right. And if you're in a rural area, it's really a lot harder because you're going to have to drive to go to different facilities. But your heart and your health is really important, and it's one thing that we've got, and we have to protect it for ourselves. So obviously more research is needed. Genetic counseling and testing, you guys already talked about that. Keep addressing racial disparities. And these are some resources that you guys talked about, and also my references. So thank you very much for the opportunity, Brianna.
Now we discussed like as far as self-care as what Dr. Lopez was basically saying, and Dr. Amy as well, just to engage in activities that bring you joy and relaxation, whether it's reading, listening to music, volunteering time, or spending time in nature. Like once I was diagnosed, and like you did discuss that, Dr. Lopez, about this as far as depression, and that is one thing I know we didn't discuss earlier, because a lot of moms don't exactly know when they're going into depressed mode, and then it's been times where I'll like the older women, it was, well, in the Black culture, I would say, that stuff didn't exist. It wasn't no depression, no mental health. Like, you're delusional. If you getting told that, or if you feel like you're scared to say that because, oh, I'm going to be deemed as crazy if I state that I think that, I'm feeling weird, then most, oh, you're feeling normal. That ain't nothing. Just pray about it. You'll get over, but we're in real time now. So as far as like being able to educate ourselves as much as we can is what, I'm so glad that the media has even brought that. It was kind of a blessing in disguise, as far as like having this open discussion, being able to network with others, and just learning ourselves, truly learning our bodies. And so one thing I do like to do, as far as when I felt like I was slipping into depression, I try to let other moms know to write things down. I don't care how you're feeling that day. I need you to write down your feelings. You need to be writing down how you felt. What is it making you feel like? Just kind of creating a little journal or a notebook, if they're able to. Because a lot of times when you are going into heart failure, you are becoming shortness of breath. And even when you're pregnant, you're shortness of breath. But it's good to keep documentations of things, because we had to literally go back and look at stuff that my sister probably wrote out. It's stuff that she was writing on Facebook, that certain things were highlighted. It's like, okay, oh my God, that could have been a cough. Like, we could have caught that, so like she was having coughs, weird coughs that was coming out of nowhere. But we didn't know. We just didn't know, so that thing can bring you to depression, and she went through, a state of depression, because what I'm going to do with my kids if something happens to me. I'm their mom, their only mother, and something end up happening to her, because she did have those thoughts. She did write letters to her kids just in case something happened to her. So it's just being able to write down, being able to just be into learning who we are, learning our bodies, learning ourselves, self-care. So I'm for that 100%. To set realistic goals, like breaking down tasks into manageable goals, both in terms of your physical health and daily activities. Celebrate small achievements and be patient with yourself. Me, oh my God, I'm a total 100% advocate of which is self celebration. And so for those that do follow me on Facebook, I don't care what I'm going through at that moment. I need to let it out. Whether you look at it as an event or whatever, if I'm going through something, you're probably gonna know. And so, and it's until I get over it. Like I always let people know, March, April, and May are hard times for me. I lost three close individuals to me around that time, and so not only that, I had to go through the heart failure after losing them, and so I didn't have that support team anymore. All maternal that side was gone. Like when Granny passed away, my sister passed away, my mom was already gone. So I didn't have that self care. So my care was my providers, or looking into it. But my dad, actually, thankfully for him knowing the symptoms, because my husband, we both were clueless. Like we didn't even know that I was going through anything that was life threatening. I just thought it was something a part of the second pregnancy. So it wasn't, even though my sister had passed away from an undiagnosed condition, but I knew it was heart related. I still didn't pinpoint it to me, but that it was going to happen to me. So then we have the manage of the stressors, the practice stress management techniques such as deep breathing, meditation, dance, or being mindfulness, and these help to reduce the anxiety and improve overall well-being. Me, I like to do fun things. I like to put awareness in certain talents and skills that I had prior to being ill. I don't like to look at myself as, oh yeah, I'm the PPCM girl, and I have to do all these disabled things now. And no, I never like thought of it like that, because even my cardiologist thought he probably, he knew I was not ordinary like the rest of his patients. Like he would tell me, he would just say it in certain things, certain ways. But being able to tell my story, being able to have the platform to be able to aware other individuals who may not have heard of this condition before, putting it in a song, making it fun for other patients that are going through something that is down. I mean, it's a devastating condition, but I didn't want it to be a death sentence, and I'm already watching how my sister, had to go through that. I didn't want it to have to end the same way, so with, God's blessing, I was able to heal from it and being able to share that story. And so I don't ever let other people shut me up. I'm going to tell the story, and I'm going to continue to do so until this condition is not killing mothers, especially young mothers. I just think it's so unfair to have a condition that you weren't educated about, to where you have kids, you want kids, or the women who try for fertility treatments that are, they're trying to have a kid, not even knowing that there's a condition connected to IVF treatment that you can possibly develop a heart complication, after experiencing this. And then, oh, I done finally had a baby, but now you're telling me my heart is bad and I don't know if I'm going to survive in the next 6 months. So that's just a lot to take in for the patient. So this is how we can make a difference as far as today. Just being for overall with helping Let's Talk PBCM, what we've been needing help with, is it to share like your personal connection or passion for Let's Talk PBCM with your network. Utilize your social media platforms, emails, and other communication and channels to spread awareness about the organization. Hosting fundraising events, which is what we are doing. We are being able to offer prizes now for women or who's ever able to start those fundraisings. More so, it's been birthday fundraisers on Facebook, and that is perfect. And so, with any virtual or in person, to engage the community and encourage support. So, revolving the organization is obviously trying to implement these magazines and being able to put them in as many local facilities as we can for our heart sisters. So, wherever state that they fall in, and some of them are in the U.S. and some of them are not in the U.S. So, the more so, the better. And then leverage workplace giving programs or community partnerships to broaden the impact, which is what we're doing. We now being on panels and or being offered certain positions in the actual collations of with healthcare providers. So that's like a biggie on our end. We're excited to be able to offer our expertise in being the patient. And then when donations are, obviously are also crucial for us to be able to continue Let's Talk PBCM. And unlike the for-profit businesses, nonprofits rely on heavily on the generosity of donors and to cover operational costs, support ongoing programs that we are trying to definitely keep going, and then expand our reach. And so the financial contributions ensure that Let's Talk PPCM can continue its essential work and grow its impact over time. So just making sure that we're able to continue bringing that awareness as much as possible. And then not only that, but also making the patients or the moms that do get this condition, making sure that they're not feeling alone and letting them all know that they're superstars. Because I always tell all the new moms that they're a superstar and they didn't get this condition for no reason. They got it for an exact reason and just the reason we haven't found that purpose yet or whatever purpose that it is. But hey, it's something. It happened for a reason. They wanted to share a prize pop quiz. I didn't know if anyone would be in here to be able to answer this. So one of our first questions, and if you all just want to blurt out, you can do that because I can't see the screen right now. So the first question is, what is the primary risk factor for postpartum cardiomyopathy? Anybody want to take a guess?
All three.
All three. Well, yeah, all three, yeah.
I have all three. That's why I said all three. All three were for me.
Okay, that's all three will work. Yes, I know the highlighted on what we discussed as far as like
Was
being African
African American.
American.
American,
Yes,
yeah.
it'll be
Well, that's me.
C.
I had
Yes,
multiple
yes.
pregnancies and I had advanced maternal age, so it was all three. I was just doomed.
Yeah, right. Oh my God. And so with I believe Dr. Thorsen, she had went over that as far as like with the African. So we've been seeing so many patients from Nigeria. Like the main part of our following on Let's Talk PPCM is Nigeria related. Like they're
Right,
Nigerian and they're Haitians. And so they're trying to figure out this condition too, because they're trying to figure out why are they getting it so much. Like they're trying to, so they done jumped into the US of things and trying to figure out, well, what is the U.S. doing? How are we able to? Because we're, they're seeing these stories pop up on these women, and their stories is being, so they're slowly starting to tell their stories too. And as you can see, you may start seeing like Nigerians, they be having they building up their medias and stuff. So they can make others aware too, because it is happening a lot there, and it's because they're not able to afford certain care that we could probably get access to here. And so then it brings us to number two. So when does peripartum cardiomyopathy typically occur? Anybody want to take a guess?
B.
Okay, let's see. Be within the first few weeks to months after. Yes, absolutely. Absolutely. So within those few weeks, within those few weeks to months after childbirth is something that we've been seeing a lot. I know that not just with myself, because we don't go just by the, per individual, but just like overall. And then, with having a support group, we're able to, that is helping a lot as far as like seeing exactly when these moms are being diagnosed. And so particularly there a lot is the postpartum period, but our symptoms and beliefs is starting in the peripartum. So it's starting before we even have the baby. And so our hearts is basically being set up again to that, what we were talking about earlier about the rapid transitioning of the heart high is basically aging really fast, so it's aging, it's already becoming enlarged because you probably have you're carrying a baby, and Dr. Thordsen discussed that as well as far as enlargement. And sometimes maybe it's not an enlargement there because maybe the mom's heart returned back to normal size and something else done took place. Maybe she drunk alcohol, after she had the baby, and then that exacerbates the symptoms and brought PPCM to, so we don't know exactly what's happening and what's taking place after these moms are leaving the hospital that can actually exacerbate PPCM to occur. So then our number three is, which of the following symptoms should raise suspicion of postpartum cardiomyopathy in a new mother? That should be easy.
A.
Yes, yeah, that's so true. The fatigue, the shortness of breath, then the persistent cough. Oh my goodness, that cough is something serious. When I tell you, I mean, you feel like you're dying from the cough alone. And then with the shortness of breath, yes, even though a lot of mothers experience shortness of breath, but when it comes to postpartum cardiomyopathy and developing, you keep the shortness of breath. Like it doesn't go away, and then it might progress over time. So, and I wouldn't have noticed my shortness of breath had I not had to walk up a flight of stairs. I probably wouldn't even noticed it, So some women aren't active after birth and they probably don't even know that they're developing certain symptoms, like even with my sister, she, had I believe she went into shortness of breath, but it took her being in a parade with her drill team, because she was a teacher and she was a drill team coach. And so it took her walking, those miles in the parade, like, oh my God, I feel tired. I can't. And that was literally 3 months postpartum. And then the fatigue, being tired all the time, that's another thing that pregnant women experience. We're tired all the time. I think from the moment you get pregnant, you start being tired all the time. So that's just, one of those common conditions. But it gets more so with the postpartum cardiomyopathy and effects on how it's taking a toll on our bodies. And I do know that, like with the fatigue, depending on the mom's activities, because we're told to take it easy and don't do much, when after we have the baby. So it's like, okay, now where our mind is focused on, okay, don't do much. I need the rest. I need to sleep as much as possible. Trying to get that, so we're not really seeing what's actually taking place. Okay. And that brings us to end of this discussion. I want to thank you all so much for being a part, and we do want to open the floor for any Q's and A's. As far as I know, some of you just dropped in here, and so if it's any questions or anything that you have from you just joining us, that we would love to be able to answer, and just discuss a little bit while we can, since we do have some time. So if you all are able to kind of sit there with us and join us for some little discussion.
In the 700s, your heart's enlarged and you have fluid in your lungs, you got to go to another hospital. And I got diagnosed at the second hospital, but a lot of the doctors had never heard of it before. They didn't know how to treat it, so it's something that is just so unknown, which is crazy to me, because the highest, leading thing of death in postpartum is heart issues. So
Oh my gosh, yes, yes, yes. And that is why we're trying to figure out who's best to partner. We was discussing earlier about, as far as like how to help the patients be able to understand the doctor's point of view as well, because we had learned that with Dr. Lopez, she's a midwife, she had to drop out today, but she shared with us about, as far as them having to get certain permissions that we were unaware about. Like, I didn't know that they have to get certain permissions as far as running BNP testing, and things that we're thinking that we could just come in and ask for, that we're not sure. And sometimes the doctors, and come on, as far as like a profession, any profession you get in, you're going to have either some type of like anxiety, as far as like, oh my God, I don't know how to tell this person that I can't, help them, or I'm the doctor, so they're in a certain place where they feel like they can't share exact certain information, as far as like making it look out of profession, because a lot of patients get triggered if they feel like they're not being treated a certain way, or if they're not being treated, expeditedly, so it's just like trying to figure out how we can help bridge that gap as well, just to see, making sure that our providers know that we're caring for them as much as they're caring for us as well. And I'm definitely glad that you were able to get that diagnosis in time. Were you, how far in the postpartum period were you?
I want to say like about a week to 2 weeks when I finally got the diagnosis. But I was about at like I think they said stage 3 of heart failure. And I have recovered a fair amount, so that's great news. But yeah, I was unaware that they couldn't just run a BNP, just because, out of all the other tests they run, it just seems like something that they should be able to. But I suppose, maybe it's just not ran as often, and so it's harder to obtain or something.
Right. Well, I know, and Dr. Sarah, you can piggyback on me on that, of that they're not seeing enough women being diagnosed with it, I'm assuming. I know in I think one of our past panels, me joining, they discussed about how it's under 200,000 women or something being diagnosed. So there's not something that they're focused really on, as far as like a quality of number. So it's like, oh, well, just the ones that are developing is kind of like you just kind of thrown to the wolves, like a
Yeah.
science experiment. So it's like, but I don't know. Dr. Sarah, are you able to kind of chime in on that? Is that like kind of, is that what it is, maybe?
Well, I think that the way that healthcare, including pregnancy care, is covered in this country really depends a lot on where you are in the country and who your insurer is. And so the way that every insurance plan, policy, hospital, city, state makes decisions about what's covered for any given diagnosis is different. And that's why it's really hard, why it's not easy to have one certain blood test added to every single woman's pregnancy, because like you just said, how many women are going to benefit from it, and is that worth, and from the insurer's standpoint, is that worth whatever cost that is? I don't think that's necessarily a charitable way to look at medicine, but that's kind of what insurers would think about it. And so my interest in especially screening women who are still pregnant is who should be screened, and let's figure out the right group of women to be screened so that it's the most cost effective, and we're finding the women who are sick. And so is that women who have a history of it? Is that women who have preeclampsia or high blood pressure? Is that women who have a family history? And then screening those women in a systematic way, I think, is one of my goals. But that's it's a really complex question, actually.
Thank you
I
so
do
much
think
for that.
I
Go
think it's
ahead.
a good goal. I mean, because at least it starts, like people talking about it more.
Hmm.
And I think for me, my cardiologist, he said, we won't really ever know, but he thinks I may have developed preeclampsia that just didn't get caught. And so it's interesting because there is, I feel like, a fair-ish amount of knowledge out there about preeclampsia, but mostly just to be scared of it, right? But then there's like all these after effects, and I think that they don't always get met. But honestly, I don't know if I had any things that would have really stuck out to make me more susceptible, I suppose you would say, to getting this. The only thing is that normally before all of this, my blood pressure was always quite low, like 110/60. And then during pregnancy, I was up, like in the 130s over something, but that's not always quite cause for alarm. And one thing I mentioned to my doctors after the fact is, I understand for preeclampsia and blood pressure conditions, you're really looking for that 140/90 or more. But I think it's always good too to look at where does a person normally sit, because if a person normally sits at 130 and now they're 140, not good, but okay. But if they're normally at 110 and now they're 130, 140, there's a bigger difference. And so that's just something I think about too with screening, is really looking into each person's individual, case and history. And I don't know, it's hard because there's such a lack of healthcare workers, and I know that they're strained and there's so many things that need to be attended to, but it just makes me so sad to think about all the women who were never diagnosed.
Yes, oh my God, I agree. And that's what we're trying to see. It's like we're able to do the panels, able to, discuss, but it's like, what is it really going to take? And so the doctors aren't stressed out. We don't want our doctors stressed out in the midst of trying to live their own lives. And then they have to come back to work, and then they have these multiple women that they have to go through and assess. And then you have these particular women that you have to focus on specifically, which is why they have specialists for those reasons. But even with it being a cardiologist, or even Dr. Sarah in her profession, she's hit with probably multiple different type of cardiomyopathies, not just that one that's just focused, or like how we had with Dr. James Fett. He literally kind of just saw that, oh my goodness, there was a need for a cardiologist within the Nigerian area and within the Haitian area, where he actually just took amongst himself to go and just start a project there on, seeing exactly what's going on. So it's just, and that's just him out of all of the studies in the world. So it's like, it's definitely difficult. And, with them not being able to have enough support and help. And then, like you said, just not, a lot of the healthcare providers we're not seeing as many, or then it's a lot of them that's being turned away from the profession because it's overwhelming. And I know that as a doula, I've been noticing that as well. As far as like the transition of the labor and delivery on how it is, and how these women are just being pulled left and right, and like they get overwhelmed, and sometimes it bleeds off into their work. And you can see the frustration, you can see, and it's just like other doulas may get attitude or get upset about, certain things that you see. But that's why you have to be a good reader in a room. I would say that's just how I do things, or based off how I do. I like to read the room. I like to know exactly what, if the physician is under any stress. Like, you can tell certain things if you just sit back and kind of observe things, or observe what's being talked about. If you're getting kind of brushed off, or if you're being, that doctor may be going through something that's totally, we just don't know. And so that's why, like, we can't be quick to judge, but also, doctors have to remember as well, like, we're not educated on what they're educated on. And, we're not looking for anything wrong to go to happen. We're just, wanting to bring a child into the world, and like I was saying earlier, we didn't know that IVF treatments, I know that was something I think we learned 3 years ago or 4 years ago, per Dr. James Fett, that IVF treatments is actually increasing the risk for moms to develop heart issues, known as PPCM. From certain medications that's used, it's probably triggering the trait. Like, if we have a genetic trait, which we also discussed earlier, that is genetics is involved. And so if maybe a great grandmother, or somebody who probably had a heart complication, or somebody who died in childbirth 30 years ago. Like, we just don't know exactly, as far as like a family history. I didn't know that my grandmother suffered from a cardiomyopathy, or a form of heart disease. They called it heart disease after her third child in the 80s. But when it got to my sister, it was, we don't know what it is. It could be this, it could be that. And then when it got to me, oh, it's PPCM. So it took like those two happening. They both passed on now, so it ain't like I could go back and ask them questions, or, well, what were you feeling this day, and what happened this day. The only thing I have to go off of for now is my sister's Facebook. So thank God she was able to kind of document. So I do think that's more, it's important, as well as that we're keeping documentations, because I think that brings us a long way too. And Dr. Amy, you could chime in as well if you feel like. And I think, Edith, did you have a question? Because I saw you come on mute. You're more than welcome to speak.
No, I was just going to add on to that part of advocating, just being an advocate for yourself and having somebody advocating for you. For my case, I did my main symptom was just shortness of breath and swelling on my feet. And I had been swollen for a while, but that kind of like towards the end of the pregnancy, I remember going in and I had gained a whole lot of weight that was not proportional to the amount of time. And my OBGYN was a little concerned, but then I mean, we didn't really go into details about it. He just said, you've gained a lot of weight in the last week. That's not normal. And I went in there for another checkup, and my blood pressure was high. I got induced, I gave birth. My blood pressure was still high post after I had given birth to my patient, to my child, and I got home. I was okay. I was tired, but then my child had some complications with his bilirubin just being high. I went back to the hospital and I had shortness of breath. And I got admitted into the hospital. But I think there's also that part of, I don't know if, I don't want to say lack of education. I think it's just lack of awareness. Because I stayed in the hospital with shortness of breath, and I actually stayed until I coded. I couldn't breathe and my heart stopped while I was still in the hospital. and that's when they after I had coded and I was in the ICU, that's when the echocardiogram was done. That's when kind of things that the cardiologist was consulted, and the echocardiogram was done, and I was diagnosed. So, I woke up from my la la land, and I was I was told that I had this postpartum cardiomyopathy, which for me was something very new and was um, very scary at the time because I had no idea what they were talking about. And I just want to thank you because, for this group and for your advocacy, because at that time I was really, I was looking for something and someone that support system, the support group. I didn't, because I did not know what the cardiomyopathy was all about. So yeah, thank you for the information and thank you for your advocacy and for the support group as well.
Absolutely. Thank you so much for sharing your story. I'm so glad you was able to find out in time. Did you say how many weeks or months postpartum were you?
Days. I was
Days.
5 days postpartum when I coded,
Oh,
when my
wow.
heart
And
stopped. Yeah.
y- yeah, and so when you went to the hospital, it wasn't even for like you said you was feeling weird, but like I know you weren't expecting like no heart complications or anything like that. So
No,
you
I
it was,
felt I felt tired, but that was
mhm,
attributed to just being a new mom, and
mhm.
I was up breastfeeding and taking care of the baby and taking care of things at home after I had been discharged. Um, so that tiredness, I mainly attributed it to not to just being postpartum. I actually developed the shortness of breath after I had taken my child back to the hospital for
Mhm.
the I'm forgetting the light treatment for high bilirubin,
Wow.
phototherapy for the high bilirubin. And I was just sitting there with the baby in the middle of the night, trying to sleep, and I couldn't lay down. I had to sit up to breathe. So I remember calling the nurse and I said, I'm having a really hard time breathing. I'm having to sit up to breathe. I cannot lay down. And she came in, she listened to me, and she said that you sound okay. It doesn't sound like there's anything wrong with you. And I told her, no, but I really, I know you're listening with your stethoscope and you feel, it sounds like everything is okay, but I really
Mhm.
cannot breathe. So
Wow.
they called a rapid response, and I got admitted, went to the emergency department. Um, they at that time they put me on a nitro drip, which helped with the nitroglycerin drip, which helped with the shortness of breath, and then I got admitted. But throughout the day, um, at some point they discontinued the nitroglycerin drip, and I continued to stay, well, really with no intervention,
Mhm.
for pretty much the whole day. And people, different practitioners were coming in and checking in on me. There was the OBGYN, the physician on the floor. They were all coming in. They were all asking me the same questions. How are you feeling? And I kept telling them that I'm still short of breath. I still can't breathe.
Mhm.
And I remember even at some point, one of the practitioners came and wanted me to take me to go see the baby. And I said, I can't. I don't think I can walk from here. I'm not, I really want to see the baby, but I cannot go see the baby because I don't feel like I'm going to be able to um, walk long enough to go see the baby.
Mhm.
But those were all, um, I, those are all symptoms that I feel like may have been ignored. Um, I got to a point where I was very anxious. I felt very anxious, I believe, because I couldn't breathe. I was just very anxious. And the nurse came in. I honestly don't know what they gave me, but they told me that they were giving me something for anxiety,
Mhm.
which helped me calm down, but it didn't really help with my breathing. And it's that, my I continue. One of my actually was one of my family members that came to visit, and they called the nurse and said that I was really having a hard time breathing. And when they checked my vital signs at that time, my oxygen was was about 70%. Um, and you know, they increased, at that time I wasn't even on oxygen. They put me on a nasal cannula. They just kept going higher and higher and higher. And my oxygen saturation was just not coming up. It actually kept going, getting lower and lower. And the last thing that I personally remember is getting put on a BiPAP. And after they put me on a BiPAP, that's when I coded. My heart stopped. Just because of the low oxygen saturation. But we're most of us talk about the being ignored as an outpatient, but even for me, I was inpatient, and all my signs were being ignored by all the practitioners that I feel like they were ignored. Maybe they were, but I feel like they were ignored by all the practitioners that I was trying to talk to, to convey the information to.
Oh my gosh, that is definitely traumatic. Oh my goodness, I'm so glad that you was able to come out of that. Dr. Amy or Dr. Sarah, is it any like do you see like where a red flag happened at? And if so, how can we or like what it was that awareness? Because she said that she think that it was basically lack of awareness as far as the condition. But if the doctors are or being on the patient's, I mean the doctor side or the of things as the patient, you're seeing a patient, but you're not sure, or it's a rare condition, so you don't want to say, "Oh, that's what it is. That's what she's having." So the thought of the anxiety of her being ignored, is there any type of preventative measures that could have took place, or what do you all feel on that?
So I think it's really hard, right, to comment on someone else's healthcare journey when you weren't there as a physician. I think the things that I can say about what I would do if I didn't feel I was being listened to, I think a little bit of it is that feeling empowered enough to be your own advocate. So, I would say things like, I'm still feeling really short of breath. Can you help me and tell me like what diagnosis you're considering, and what we're going to do about it, or what do you think this is due to? And so I think that's something that I would say, like, ask open-ended questions of your healthcare providers, but not in a way that makes it seem like you are challenging them, because when someone is challenged, I think it's in our nature to become, unfortunately, defensive, and that's not productive for anyone. But if you can say things like, I'm concerned about this, I don't feel, I'm concerned about my breathing, I don't feel strong enough to walk, what do you think is happening to me, and what are we doing to help it?
Beautiful. Love that. Okay. So that is one thing I know that we're trying to make sure with the patients, or being on the patient side of things. So that is definitely something to take in consideration as far as like, because I know that a lot of patients go in as under Dr. Google. So what we call Dr. Google. Dr. Amy, did you have maybe a chime in on that as well, as far as like your expertise?
Well, it kind of, the conversation is really making me sad. Again, I think, as Kayla said it about the women that weren't diagnosed, because it's something that we do see in review of records where there was complaints, but there was a delay. But it's like Dr. Thordsen said, well, she didn't say this, but healthcare is very complicated, and there's a lot of players, and there's a lot of things going on. I think you've said this, Brianna, several times. But I think that the what would help is the persistence. So I know it can be intimidating in those kind of settings, but the persistence, because you really know when something is not going right with your own body, yourself the best. And that's why these conversations right now is why the CDC started this campaign on hear her, listen, and how listening can save lives. And so for listening to save lives, someone's got to be talking. So going back to what several people have said is just the importance of advocacy and persistence. And it's true, like escalating it with rudeness or confrontational is not going to help. But making sure that you're being heard and not giving up is really important.
Yes, absolutely. Thank you so much for that. So I'm just overwhelmed with a little bit of both sadness and happiness because I'm just glad that we're able to now to be able to discuss on what we're seeing and how we're able to basically help with the situation. Because I know that I stated before, and even with the heart sisters that are in here, I know that you can probably tell that sometimes we have those hostile patients that's in the group and they want to attack the physicians, and we're like, it's not about we can't really point fingers and stuff. It's about knowing we have to learn our bodies and know we're not educated and not doctors on, as far as like the name of each body part or what we're dealing with or what we're experiencing. But I feel uh, like in my case, on what made my story so interesting in the first place was because I had my sister had passed away, which was more like an alarming for me. It was like an alarm that went off on, oh, okay, I do know like putting the pieces together, puzzle pieces. I had puzzle pieces, but with other heart sisters, they don't have those certain puzzle pieces on like knowing that, oh my goodness, I think it's something wrong. And so I have been seeing a lot more women that kind of that get aware about PPCM and they feel like they're developing PPCM, but then it's not PPCM. And so it's like not trying to put after we saw like what it was doing as far as like trying to educate the community about it was more so beneficial as far as educating or getting involved with the healthcare themselves and the birth workers, midwives, just to be able to see how we can go around as far as just in case the mom is not aware of her bodies and what she's going through, which is what we've been hearing because, and with me, I was able to and I didn't tell my doctor what I thought was wrong with me. I didn't go on Google. I didn't do any of that. I just told her, hey, I feel like a weird thing happening in my heart, and I was carrying my baby, and I just wanted to make sure my heart was okay because what happened with my sister, right? So like, even though she wasn't given a diagnosis, it was something wrong with her heart, and I just didn't know if I inherited it. But that little small thought in the back of my mind, I was right, basically. Like I end up developing it, and but I kind of knew to ask for certain methods. But what if my obstetrician would be like, "Oh no, you're too young for heart problems"? Like we've been hearing these other patients, they go to their doctors, and the doctors is stating that they're too young for heart problems. So if you're getting told that you're too young for heart problems, that's not going to be on your mind anymore, right? Like so. I just think that was very interesting conversations today that took place. I know I don't want to keep everybody's longer than what we have to be here. I know we had until 2 p.m., but this has been a enjoyable conversation. I've been learning a lot, even though as far as one of my expertise is, being able to educate around this condition, because as a patient advocate, we're also aware and expertise in our own bodies now and knowing what to look for and how we can help, because some of us, or a lot of us, have daughters that we want to make sure that we're around for, and that just in case they need to be aware of certain things, certain signs. So I think, definitely just keeping the awareness going, the education that we can. You all are doing a beautiful job in your fields. And I just want to applaud Dr. Sarah, Dr. Amy, Dr. Lopez as well, even though she's not here, but just let her know we're giving her an applause, and what you all have been able to bring together today, because it's just been beautiful. I feel like it'll be definitely helpful in going forward and just trying to strengthen the conversations around it. And then, just hopefully bring some awareness around you guys and your expertise as well. So I'm going to definitely see how we can chop up and edit this video and see how it can be used in the most beautifulest way. And if there is no other questions or anything, if anybody has any other questions or anything before we say our goodbyes.
Thank you for the opportunity to be here this afternoon with you. I'm always amazed at the work you do, and so important. And it was a pleasure to hear from Dr. Thordsen as well, and Dr. Lopez. I learned a lot myself, so thank you.
I second that. Thank you for the opportunity.
I would like to also say thank you as well. I learned a lot. I've been quiet a lot because I was just diagnosed almost a year ago.
Oh, I'm so glad you was able to get that
So
diagnosis.
I was one of the people that was diagnosed 4 weeks postpartum because I'm Black.
Oh no,
I'm just joking.
no.
I'm just joking. That's not why. I was stubborn at home, thinking that it was just asthma, and because I'd had my first C-section, that was the reason for my shortness of breath and severe tiredness. But lo and behold, it was because of PPCM. But yeah, I was diagnosed at like 4
Wow.
weeks postpartum.
See there, that's what I am saying. So yeah, definitely I think, do you feel like more awareness around the condition would have been helpful, or do you feel like, oh, my doctors probably weren't aware of what they felt was happening?
This was my 6th baby. So the first 5 were all vaginal deliveries, and I was like up and running around like after like 3 days of delivery, like I was fine. And
Mm-hmm.
I had to have a C-section with this baby. So I attributed everything to it being a C-section. I just was totally clueless. Plus, my OB I had him for like over 20 years for the first 5 kids, and he retired. So I had a whole new OB, a whole new everything. So I just assumed he knew what he was talking about. And I assumed since I'm having a C-section, that's why they're so tired and takes longer to recover. So I just didn't know. If I would have known, I would have went to the ER like way ahead of time, because I remember going to a 2-week follow-up after my C-section, and the doctor was talking to me, and I couldn't even answer questions. Like I was so short of breath and just so tired. I was literally falling asleep while he was talking to me, and I'm thinking like maybe if he'd have diagnosed me then, or noticed the symptoms then he would have, because my legs were swollen. They were huge. But I just assumed it was all C-section after birth symptoms. I didn't know. I had no clue.
Yes, definitely. See, that's another thing. So we're just trying to make sure, and that's one thing I think, were you on here when we discussed about like how they have to get certain permissions and everything before like they're able
Yes.
to? That is like definitely something that patients should be aware of. So I'm
This
like
was like
thinking,
really informative for me, as even with the depression, because this year's been very, very, very hard for me as far as like my mental health. And then even like when she said like not wanting to go out and do anything, like
hmm
I no longer grocery shop. I don't like to be alone, because I was just like, what if my heart stops? What if this happens? So like it felt
right.
good to know that I'm not the only one that feels this, because that's been me this whole year. Like I don't go anywhere. I'm talking to a therapist. I just got a therapist. So I'm like, this cannot be good for me.
Oh.
So yeah, it's been really rough for me to go from being like totally normal to just hearing, oh, you
hmm
have congestive heart failure, sent home with a life vest, and you still have a husband and 6 kids to care for, and you're like, wait, what? There's
Exactly.
no
I'm
follow
like,
up on how you feeling or anything. It was just me against the world and my kids. So I was like, this has been very like helpful for me. Like
oh.
seriously.
I'm so
So
glad. I just
yeah,
pray that it's able to be a blessing for all, and even the other horses. That's why I was like, well, I didn't want to share it publicly because, we was trying to keep like discreet conversation going. But it's just a lot of important information, and I know that needs to be heard. And it's just those highlights that we don't know or haven't been aware. I don't think I've heard some of the discussions today in any of the other panels that I've been a part of. So I mean,
this was really good for me. It was really good for me. I needed to hear like everything.
no,
I mean, I
bless
joke a lot.
you.
I'm like, oh, it's because I was Black, but I was just joking. I mean,
No, no, it's okay because we
it was
know
just,
it's the high
but
incidence there. It's definitely in the Black community, but we're unaware of those because, like I was saying earlier, the mental health, all that stuff was known as delusional. In
right, especially because when
growing
I told
up.
people I was
So,
seeing a therapist, my mom, I'm like,
right?
well, you're just pray about it. And I'm like,
No,
no,
I need
something is
more
really
than
wrong with
that.
me. I don't go anywhere. Like I don't go grocery shopping anymore. I literally I haven't even slept in a bed since diagnosis. Like I sleep in a reclining chair.
Oh, see, and
So
that's
just because I'm
another
scared to lay
thing.
down, I don't know. I don't want to feel the way I felt before I was diagnosed. I don't ever want to feel like you're drowning again. So like I'm
Mhm.
terrified to lay down flat or even in a
That
bed. So
anxiety.
yeah,
I was
it's
like that. I
bad.
didn't want to lay on my left side for a long time because I did not want to listen to my heart. Like I didn't even want to hear it beating. Like because I
I
knew it
just
was beating funny.
I want to say, I think it was really strong of you to share all of that. Um, and you are so not alone. And honestly, it's refreshing to me to hear those things too, because it's almost been 2 years for me, and I just started sleeping on my left side again, and
Oh
so
Oh
my
my
I get
gosh.
god.
I get it too. It's you're so afraid, and I think you have PTSD,
Mhm.
and yeah,
She
same
just told
thing.
me that. I went to the therapist yesterday, and that's what she just told me.
I
So
mean,
Wow.
it
like,
is. It's
hopefully one day I can sleep
traumatic.
in a bed again. Because not sleeping in a bed, I'm like, I know I'm not sleeping good, which is not good for my heart. But I'm like,
Oh.
I'd rather sleep in a reclining chair than to lay down and be like, what if I don't wake up? What if? The what ifs are just
Mhm.
It's
horrible.
okay. I mean, it's not okay because you shouldn't have to go through it, but you're not alone.
Right.
We totally understand. And what you're thinking and feeling isn't crazy. I think it's just things that come along with something like this.
Yes, absolutely. It's a heartbreak. And that's why I just share it. And that's why like my family members treated me weird when they saw that I was trying to educate. Like it was something out of my norm. It was not you don't see me on the news, you don't see me talking and discussing these things with so that wasn't something I was doing prior to being diagnosed. But like when I lost my sister, it people don't know how a certain condition can take you and transition your thoughts and your mind and your process. So a lot of my family member that wasn't around to support anyway, right? Like had so much that, oh my God,
And you know
you
what's crazy is
really took
because
this.
what's crazy is because you look totally fine on the outside, and then when
Exactly.
people look at you and you're like, "Oh, you have a
Like
heart
I have a
problem," I'm like,
whole
but
implant in my chest.
right, and they don't think they think you're like making it up that you have like 2 good days, and then the next 4 or 5 days you're like exhausted, like you've
Hmm.
been hit by a Mack truck, and you're
And
like,
they don't believe it.
"But you look fine." I'm like, "I'm not fine."
Right. Oh my gosh. I had to, I end up, that's why I think when I know Dr. Amy follows me on Facebook, so Lord, I don't be knowing if I be in professional mode or not, because I be telling people, look, if you want to see a professional side of me, please follow my professional side of my profile, because I have like 2, 3 different profiles. So but if you want to just know me and just there and what I be dealing with behind the scenes of this, like even with no support, whatever it is, I share it, because at the end of the day, I like for things to be documented. If anything was to happen to me, I want my kids to know exactly how I was treated, how things was happening, what was going on. Like it needs to be something there as far as like to tell the story. And so that's why I'm so for when we do post our stories on the blog page, it's like every time one of those stories pop up, it's like another reminder that no, we need to continue sharing this information because it's just so unfair, and I wanted to do say happy Mother's Day, happy early Mother's Day to you all. I'm praying that we're able to just get through another year, being able to focus and doing what we can do is what we're doing. Even our doctors, our care providers, they need the love too because it's just so much, and they don't have to dedicate their time to be able to try to learn and further, this the research around this condition. It's very important, whether they know what we go through behind the scenes or not. But that's why we're here to be able to merge and try to bridge that gap so they can know and understand, oh, okay, well, my patient is not looking at it like this. She's going through this, or, they had a death in the family and now she's going through this. And, so, but then we get pointed to a therapist. Well, because your doctor can't sit there and listen to all of that. If it's a cardiologist or if it's a primary care, they're not trained to listen to like certain things that they have to do. And then they have to get on to the next patient. So it's just a matter of empathizing with everyone and making sure that we can just kind of keep a peaceful vibe of transitioning. Because I know I wasn't able to get like a connection with my obstetrician until she left the state, and then I was able to get her cell number. We was able to kind of keep in touch like that because now she's not my doctor anymore. So it's like it wasn't really breaking a rule or anything like that. But so that's just another thing that just kind of transpire. You just never know what happens behind the scenes and after, which is why I'm trying to make sure we actually bring that to the forefront so people like Dr. Amy and Dr. Sarah, they are aware of, this is actually what's transpiring. And now they have the awareness to be able to go and say that in the rooms that they're able to be invited in. So I'm just praying that it's able to, bring the education and the discussions that is needed, because everyone's story is important, even our providers. And, I just praying that we can bridge the gap the best we can so mothers can stop dying and leaving their kids,
Right.
um, you
Exactly.
yeah, because that sucks. But I just want to thank you all so much again for joining in. We didn't have a lot of the people that did sign up join in today, but I'll definitely be able to see how we can get the information out there to share what we can. And if there's nothing else, thank you all so much for y'all time today. And we can go ahead and say goodbye.
Thank you.
Bye.
Thank
Thank you.
you. Bye, everybody.
Thank you.